Welcome to Crash Cart Nursing, where we help resuscitate your nursing education one topic at a time. Hey, welcome back to Crash Cart Nursing, the podcast that takes your nursing education beyond the textbook and straight into the real world practice. I'm your host, Nick McAllister. I'm a nurse educator and the person who's going to make sure you actually understand nursing, not just memorizing it for the test. Today, we're tackling some of the most critical aspects of pediatric nursing, and that is medication administration, pain management, and hospitalization. This is where precision meets advocacy, where we balance science and compassion, and where our role as nurses can truly change lives. I've got a personal story to share with you today, one that highlights why knowing pediatric medication dosing is absolutely essential. We'll also throw in some case studies, interactive scenarios, and practical nursing tips to make sure you walk away from this episode feeling confident and prepared. So grab your coffee and let's get started. All right, let's talk meds. Pediatric medication administration is nothing like adult dosing. So if you are used to adult medications, we want to pause where we're at and think about this really closely, because with kids, the margin for error is tiny. One wrong decimal place and you've either underdosed a kid or worse, you've overdosed them. I was working as the charge nurse at a critical access hospital in small town USA, working in med-surg. And at this particular critical access hospital, if you were a med-surg nurse, you were often a baby nurse if a baby was being born. I will never forget this day because that morning a baby had just been born and I was coming on shift. As soon as I walked into the unit, I noticed that there is a newborn at the nurse's station in an infant warmer. We did not have a nursery, so this was kind of our makeshift nursery. You know, the parents needed a little bit of sleep. They were tired, so we wanted to help those exhausted parents get some rest. As I look at this baby, I just notice something is off. Baby looked a little bit dusky, and the nurses were already providing care for respiratory distress. So our family practice doctor, he was called in and he was there, and he was actually speaking with the intensivist at our local children's hospital. And they decided that they were going to admit this baby because baby just wasn't looking great. We didn't deliver high-risk babies at this critical access hospital. This was all, standard by the book. Everything is healthy during pregnancy. Everything looks good. And so here's where some things went wrong. So the intensivist gave the provider an order and told him to start maintenance fluids based on weight. But the provider who was there with us that day, he is an adult doctor a majority of the time. Now, he's family practice, so he does treat moms, babies, he delivers babies, does all of those things. But a significant amount of his practice was based on adults. So he ordered the fluids, and he had just actually recently taken neonatal resuscitation and a couple weeks before, so it was fresh in his mind. And I say this because he and we actually debriefed this whole situation. So, and I know that his big thing was he wanted to make sure that people understood some of the takeaways that we got from this. So when he ordered these fluids, he ordered them in milliliters per kilogram per hour instead of milliliters per kilogram per day. So that may not sound like a big deal, but it was. The fluids contained some dextrose in them. The baby's blood sugar had skyrocketed. We're over 600. The worst part is that multiple nurses questioned the order. They recognized something wasn't right, but the provider insisted, and the fluids were given anyway. He actually rationalized it, thinking, maybe we're doing a little bolus here. We're not going to run at this continuous rate. Transport will be here in a few minutes. We'll change this over. It's, he's thinking, okay, we're just trying to get this kid perked up a little bit, and then we're going to change it. And so he actually talked himself out of it. So this is why nurses, we have to advocate. If we know something isn't right, we got to speak up. We got to escalate it, and then don't back down. Precision in pediatric medication isn't just a best practice. It's life or death for these kids. So the golden rule of pediatric medication administration is this: weight-based dosing is everything. Pediatric meds are calculated by weight, or kilograms, or body surface area, BSA. A decimal in the wrong place can mean 10 times the dose. Okay, 10 times the dose. That's huge. So we have to double check everything. Number 2, we need to know high-risk medications. Opioids, insulin, anticoagulants, aminoglycosides like gentamicin, and IV fluids with dextrose always require extra caution. We always verify dosing with a second nurse, especially for high alert medications. Facilities that I've worked at, all pediatric medications are required to be signed off by a second nurse. But that may not be the stance of your hospital system. I'm encouraging you, add that extra safety for yourself. Add that extra safety for your license. The Board of Nursing, they can have judgment on your license. Even if you go to court and they say, well, it wasn't your fault, you abided by the policies and procedures of the hospital. If you have a fetal demise or something like that, it will go in front of the Board of Nursing. I promise you. And I want you to understand the language that the Board of Nursing presents. And that is, what would a prudent nurse do? Okay? A prudent nurse would get a second nurse to sign off on this. So it may not be in the policy and procedure. And may you not get in trouble within the policy and procedure. Sure, you might not. You might get away with it from that standpoint. But are you going to be able to live with yourself, for one, if you kill a kid? And then secondly, would a prudent nurse ask for that verification? And the answer is yes. Prudent nurses are safe nurses. Prudent nurses do extra things to ensure safety. So even if the policy and procedure is not rigid, I want you to make sure that you are doing things that protect yourself and your license. Next, pediatric patients can't always tell you something is wrong. Infants and young kids won't say, hey, I think I'm having an adverse reaction. Instead, they might cry, stop eating, or become lethargic. As nurses, we have to recognize subtle signs of toxicity. A provider I used to work with, he would say that pediatric nursing is basically vet medicine. So if you wanted to be a veterinarian at some point in your childhood and you ended up in pediatric nursing, just know that's kind of where those two overlap, is that neither of them can tell you what's wrong with them. The importance of double checks and overrides. So know your institution's medication administration policies, including barcode scanning and verification requirements. If a provider's order seems incorrect, escalate concerns to pharmacy, charge nurses, or patient safety teams. But don't do the task until you have gotten clarity on why. Don't think, I shouldn't ask somebody because they're going to think that I'm stupid. Sometimes providers make mistakes. Sometimes we make mistakes. We're all human, and we need to have that freedom to be human. But when we see something that doesn't look right, we got to say something. And don't let somebody just blow it off. Now, there are evidence-based tools like Team Steps, which can be really, really helpful for this. They have the CUS acronym. And the way we use that in situations is we use those keywords like, I'm concerned about this dose. I'm uncomfortable with giving it because of this. And I need to stop because this is a safety issue. Most providers who have been in healthcare for any length of time have heard of the CUS acronym, and if you use it at them, oftentimes the thing that they will say is, wait, did you just cuss at me? And I don't mean using foul language. I mean, if we're giving that framework of I'm concerned, I'm uncomfortable, this is a safety issue and we need to stop. If we're doing that, they pick up on that language, and it is an evidence-based tool that works in crucial conversations, and that is what these are. These are crucial conversations. Don't just override it. Don't just skip the check because you don't want to be seen as stupid or incompetent at your job. I guarantee you, people involved will appreciate it if you have safety concerns. That's our job, is to ask. We also want to be mindful of barcode scanning. If a medication is scanned and it comes up that it has any kind of error message, read the error message and then confirm, is what I have actually the correct product? Sometimes you may have the correct medication, but you might have the wrong concentration. If it's telling you that there's an issue, there is likely an issue that you need to resolve. So don't just override it. People will do that. They'll make med errors and not even realize that they've made a medication error. Let's say that you have a concentration of a medication that's supposed to be a 1 milligram per milliliter. And what you actually have in your hand is the correct medication, but it's a 10 milligram per 5 milliliter. At that point, we would be giving 2 milligrams for every milliliter instead of 1 milligram for every milliliter. And the problem is that people will look at this and they scan it and they're like, well, I have the right medication in my hand. and it's not scanning. And so Epic is stupid, or Cerner is stupid, or insert whatever medical record system that you're using. And we assume that we are more intelligent than the computer system. Understand those barcodes are uploaded for a reason, and they are trying to keep you safe. And if you are overriding it, you are defying the point of why we have those systems. So if it's giving you an error, take a second, really evaluate it. And if you can't get it to go through, don't just override. Get a double check from somebody who is going to look critically at it. If you have a pharmacist, talk to the pharmacist. I'm telling you, those safety checks are in place for a reason. And when we bypass them and think that our brain is more analytical than the brain of the computer, I can guarantee you in many cases, there is actually a problem with whatever we're trying to do. And sure, you can manually override it, but it is not a best practice. Now, pain management in pediatrics isn't as straightforward as adults. Kids express pain differently, and assessing it requires different tools. If we don't manage pain properly, it can have long-term consequences on development and future pain perception. So how bad does it hurt is not something that works. It just won't work. That is not an evidence-based tool. That is not a tool that is approved. Okay, so we can't just ask how bad does it hurt. We need to use an appropriate scale based on age, appropriate pain scale based on their age. For infants and toddlers, we use the FLAC scale. This is face, legs, activity, cry, consolability. So we're looking at, do they have a grimace on their face? Are their legs moving? What's their activity like? Are they appearing like they can't get comfortable? How is their cry? What does it sound like? Are they consolable? A non-consolable child is non-consolable for a reason. They usually have pain or something going on that we need to address. The FACES pain scale, preschoolers and up. Kids point to a face that shows how they feel. The FACES scale is one that allows us the opportunity to compare the subjective and the objective nature of a complaint. What is their interpretation of how bad they feel like it hurts? And then also compare that with what the objective data is, which is what's in front of us. What are their actual behaviors? How are they acting? Are they grabbing at their stomach? Are they guarding? Are they notably uncomfortable? So it's one of those things. It goes back to the same way that when we are talking about a patient who says that they are short of breath, there are two kinds of shortness of breath. You can be notably short of breath where I can tell that you are in respiratory distress. And then there's also, I'm short of breath. I feel like I can't catch my breath, but I'm able to talk and I'm able to move and I'm able to do things. That's where we're comparing our subjective and objective experience, right? So the subjective is my perception of this. The objective is this is what others can see as outward manifestations of what I'm describing. And then as kids get older and in the teenage years, we can have them rate their pain on a scale of 0 to 10. And remember, pain is what the patient says it is. Now, some pain management strategies. Medications. Acetaminophen and ibuprofen are first line. Opioids can be used for severe pain. Distraction techniques can be helpful. Bubbles, cartoons, VR headset. It works. I promise you, distraction is a very, very powerful thing. Parental presence. Sometimes a parent's touch is the best pain reliever. What I would also recommend, though, is if you are doing a painful procedure, something that you know is going to cause a problem, obviously we advocate for orders for pain medication for these kiddos before we do things that are going to be invasive. Secondly, if you're holding a kid down to do something, maybe they got to look at their ears. The kids aren't wanting it to happen or whatever, something like that, or you're putting stitches in. I would highly recommend have the parents be there. Let them be the gentle comfort. Don't make them be the bad guy who actually has to hold them down tightly for two reasons. Number one, parents often let go before we're done and they can actually compromise whatever it is we're trying to do. So parents don't want to be mean and we don't want to make the parent be the mean one. And then number two is sometimes they just cannot physically do it. They don't know exactly what we're asking them to do. It's better if we have a staff member. So always take in appropriate staffing with you. All right, let's talk about hospitalization, the emotional and physical impact on our pediatric patients. Hospitalization is stressful for anyone, but for kids, it can be terrifying. They are in an unfamiliar place, surrounded by strangers, and often don't fully understand what's happening to them. How hospitalization affects children. Infants may experience disrupted bonding with parents. Toddlers often show regression, toilet training, kids start wetting the bed again, behaviors kind of go backwards. School-age kids need reassurance and honesty. They pick up on fear easily. And teens struggle most with the loss of independence and privacy. So in places that we can provide independence, decision-making, and privacy, we need to do that. Now, let's talk about the power of play in pediatric nursing. Medical play. So this is kids' toy doctor's kit, stuffed animals getting shots. Those things help with fear. Creative play like coloring, music therapy, those help provide emotional expression. And physical play, even in the hospital, movement is equal to stress relief. Okay, so we want kids moving. We want them doing things that are going to help create that joy, because joy is a great medicine for them. All right, nurses, that wraps up this episode of Crash Cart Nursing. I'm so glad you came. I hope you found today's discussion helpful as you continue your journey in nursing. Remember, every shift is a chance to learn, grow, and make a difference. So stay curious, stay confident, and most importantly, stay compassionate. If you enjoyed this episode, don't forget to subscribe so you never miss a new one. And if you found this helpful, share it with a classmate or a coworker. Let's build this community together. Until next time, keep your crash cart stocked, your caffeine intake high, and your assessments thorough. See you in the next episode.